Okay. Okay, all right, there it goes. So let's go back to the share screen. Okay, great. And then I figured as we do this, if I kind of type along, I also can send these notes out to you guys, or if you want to take your own notes, that's fine. But we can kind of make a little bit of a collective Word document as we do this. So I picked shock as our second lecture topic for this series, because I think this is something that we all see really commonly. And if you kind of think to yourself for just a minute, what you picture when you think about us seeing a patient in shock, I think we all kind of clinically see that dog or cat that comes in often as a stat to the emergency room, or sometimes as an appointment, because clients don't always know how sick they are, and they're fairly flat and non-responsive. And I want to talk a little bit about what's going on physiologically with those patients, so we can talk about the different ways that we treat them. And there's actually 3 major categories of shock that we see really commonly that are all treated fairly differently. So it's important to kind of recognize all of those patients might look pretty similar when they come in the door to us, but they may have different mechanisms for their shock and different things that are happening in their body that will determine how we treat them. So shock, what is it and what can we do about it? In terms of a true definition of shock, as we're picturing that patient who's on the triage table, the actual medical definition of shock is either impaired utilization of oxygen by the tissues or impaired delivery of oxygen to the tissues. So if I can flip around here just a second, this is a kind of classic shock diagram that we talk about in both human and veterinary medicine. And I'm going to go through each of these things. But what we're looking at as a whole here is DO2, which is delivery of oxygen, delivery of O2 to the tissues. And when we think about normal physiology, that delivery of oxygen to the tissues really just depends on 2 major things. So it depends on oxygen content, right? It depends on how much oxygen is in your body to be delivered to the tissues. That's this CaO2. And it depends on cardiac output. So the ability of the heart to pump blood containing oxygen to the tissues. If we think about oxygen content, that depends on a few different things. So it depends on the hemoglobin concentration in your red cells, keeping in mind that hemoglobin is the molecule that carries oxygen in the body. So if your body doesn't have adequate red blood cells and hemoglobin to carry oxygen, that's going to be a problem. It also depends on your oxygen concentration or oxygen saturation of those hemoglobins. So you might have plenty of hemoglobin, but they might not be carrying oxygen because of some kind of lung dysfunction or tissue exchange problem. And then it also depends on the partial pressure of oxygen within your blood. So there's a little bit of oxygen in our bloodstreams that is not actually bound to hemoglobin. It's free oxygen. And that makes up a very small percentage of the oxygen in our body, but that's the 3rd factor. So oxygen content is one part. And then cardiac output is the other part. So cardiac output depends on your heart rate, how many times your heart beats per minute, and then also your stroke volume. So the amount of blood that is being ejected from your heart with each heartbeat or with each stroke. And that depends on all of these different functions of the heart. So it depends on your preload, which is the stretching of your heart muscle during filling. It depends on the afterload, which is basically the pressure against which the heart has to contract to eject that blood. It depends on your contractility, so how well your heart is beating. If you've ever seen a dog with dilated cardiomyopathy, when we look at them with brief ultrasound in the emergency room or in cardiology, and you can tell that their heart is just barely contracting, that would be a patient that has poor contractility, and that could lead to poor cardiac output. And then it also depends on compliance, which is how easily the heart can expand when it's filling. So these 2 major factors, cardiac output and oxygen content, are the big things that determine oxygen delivery to the tissues. If we can't get adequate oxygen delivery to the tissues, that is going to lead to a patient developing shock. And that that is important for us to recognize, because not only will it make the patient look flat when they come in the door, but on a cellular level, if the cells are not getting oxygen, the organs are not getting oxygen. And if the organs aren't getting oxygen, they're going to be unhappy, right? We're going to see things like arrhythmias. We're going to see poor blood and oxygen flow to the kidneys and development of acute kidney injury. We're going to see poor oxygenation and difficulty breathing. All of those things are eventually going to lead to patient death if we don't recognize and address this syndrome. The other kind of less maybe common or clinically recognized form of shock that we don't talk about as much is impaired oxygen utilization by the tissues. So maybe all of these parts are working, cardiac output is appropriate, oxygen content is appropriate, but for some reason the tissues are not able to appropriately use oxygen. And that would be a more typical scenario in something like a septic or distributive shock. We're going to talk about that, but usually those tissues are getting oxygen, but they're not using them appropriately. Does anybody have any questions about this diagram? If you want, you can type, you can talk, you can interject however you'd like as we go along. But this is kind of a classic shock diagram that it's nice to use to think about where you think there might be dysfunction in a certain patient. Okay, so if we come back here to kind of the idea of shock and impaired oxygen delivery or impaired oxygen utilization, there are three major types of shock that we usually talk about in an emergency or critical care setting. Does anybody know what any of them are? Oh, you can't see the diagram? Hold on, can you see? Let me just go back and see if you can see it now. I don't know who that is, but can you see it now if I flip back and forth? Somebody tell me if it's working. You can see my notes. Okay. Can you see this PowerPoint picture? Come on. Okay. Hold on. I'm sorry, you guys, I'm really good at technology. Okay, so this is my notes page. Hold on a second. All right, what if I do stop share? 1 second. Sorry, guys. Okay, can you see it now? Yay. Okay, I'm sorry about that. I can't flip back and forth, I guess. So just to quickly go over this one more time, and I'll send this out to you guys too so that you have it. And then I'll come back to all of your lovely answers about shock. So oxygen delivery at the top, DO2 is oxygen delivery, depends on cardiac output and oxygen content. And these are the different components of each of those. Okay, so let's go back now. Okay, now we're back to the Word document. Okay, so we have a couple answers in here about different types of shock. And I think that Tommy had one back here. Okay, so Tommy said cardiogenic, neurogenic, and septic. Those are all good answers. And then I think Britt had an answer down here too. Compensated, decompensated, and cardiogenic. Okay, good. And then Emily, hi Emily, said hypovolemic, septic, and cardiogenic. So none of your answers are wrong. Some of them fall into a couple of different categories though. So when we think about the really big kind of three classic categories of shock, Emily's got it. Emily cheated, Stephanie said. Yeah. So hypovolemic, I think, is probably the most common type of shock that we encounter. Cardiogenic shock would be the second one. And then septic, or what we call distributive shock, would be the third type. And the other types of shock that some people have mentioned, neurogenic is kind of a smaller category. The decompensated and compensated Brit kind of fits into this septic distributive shock. So we'll talk about that too. But these are the three big ones that I think we see most commonly in the emergency room that we're going to talk about today. So to think about hypovolemic shock, what do you guys think about when we think about hypovolemic shock? What do those patients look like when they come into the emergency room? Blood loss, good. Low BP, good. Anything else? So a little bit of it is in the name, right? Hypovolemic means low volume. So these patients are in shock. Great, Tom. So Tommy said decreased perfusion because they don't have either enough volume in their blood vessels or enough filling pressure in the heart to deliver volume, fluid, to the tissues and hence oxygen to the tissues. And so usually these patients will, like Stephanie said, have a low blood pressure. If you're kind of thinking about your triage exam of a patient who has hypovolemic shock, we're often talking about patients who have pale mucous membranes, who have a prolonged CRT, keeping in mind that a normal CRT is about 1 to 2 seconds. This is going to be a patient that you're going to kind of push on their gums, and it's going to take a little bit longer for their capillary refill to come back because they don't have that adequate volume for it to come back normally. They may have a high heart rate, so they could be tachycardic. Kitties are weird in that kitties in shock will often also be bradycardic. So don't be surprised if you see that in a flat cat that comes into us. It's not unusual that sometimes they'll be tachycardic, sometimes they'll be bradycardic. They'll have poor pulses. They will have a low blood pressure when we check it. They may have increased respiratory effort. They may be mentally dull. All of these are kind of classic things that we would think about when we think about a hypovolemic patient. And just to go back here for a second, keep in mind that hypovolemia and dehydration are not the same thing, right? So a dehydrated patient is a patient who has decreased interstitial volume, which means that their fluid volume in their tissues is low. A hypovolemic patient is a patient who has low intravascular volume. So their fluid volume in their blood vessels is low. A dehydrated patient should not be cardiovascularly unstable, should not be in shock unless they have severe dehydration to the point that they are actually becoming intravascularly volume underloaded because they have had so much fluid loss. So they're not the same thing. Also, hypovolemia is something that we want to correct really quickly. Dehydration is something that we're going to collect slowly, usually, or correct more slowly, usually over hours to a day or two, depending on how dehydrated they are. What else? What do you think would be some potential causes of hypovolemia in a patient? I know somebody said blood loss. What else could make you develop hypovolemic shock? What would be some examples of things? Okay, so Emily's saying external losses, internal losses. Can you expand on internal losses, Em? External losses would be like bleeding, but what else?
I don't know, I guess internal losses like within the body. So your abdomen, your thorax, things like that, I guess.
Okay, like internal bleeding.
Internal bleeding, fractures of long bones, things like that.
Great. Okay, good. So yeah, if you guys remember Millie, the Doberman, who was with us for a bit last week and I think went home yesterday, she had a big femur fracture, and bleeding into long bones can actually be a really common place where you can lose quite a bit of blood. Tommy said blunt force trauma. So yeah, definitely a blunt force trauma could make you have internal bleeding. We often will see dogs that are hit by car or have other blunt force trauma and have a hemothorax or a hemoabdomen. Kara said third spacing. So yeah, so third spacing means that your body may potentially have enough fluid in it, but that fluid is not going into the right place. So recently we had a kitty I think who maybe had something like a high GI obstruction and just all of his fluid was pooling in his stomach because he couldn't pass any fluid through his intestinal tract. And so he was accumulating fluid in his stomach, or sometimes they'll accumulate things like ascites because they're having trouble putting fluid in the right spot. Stephanie said a ruptured mass. So yeah, definitely something like a splenic mass causing a hemoabdomen that could cause hypovolemic shock. Protracted vomiting would be something that we could see that could make a patient develop hypovolemic shock if they're really losing a lot of fluid that way. Dogs with parvo, right, that have all kinds of diarrhea and are losing volume that way can first become dehydrated, but then eventually become hypovolemic because of that. Yep. Okay. So Kenny said pancreatitis too. That's definitely a situation where in severe cases, they can get ascites and develop hypovolemia. So there's a lot of different things that can cause hypovolemia. So if you see a patient in hypovolemic shock, how do we want to think about stabilization for these patients? What are some things that we might want to do as we're triaging them on the emergency room floor? Fluids. Yeah. Okay, great. So fluids are going to be really important for these guys. Anything else that you might want to think about? We'll come back to fluids. In general, for patients with shock, anything else that you might want to think about? Vasopressors. Okay, good. Telemetry. I like it. We'll come back to vasopressors too. Telemetry is great for monitoring, and I love that as a monitoring tool, especially as we're resuscitating these patients. Like we talked about a little bit last time with triage, it's a really nice way to kind of monitor them as we're treating them. Blood pressure, temperature. Okay, so good. Vitals, oxygen, and warming measures. I love it. So oxygen is going to be an important initial stabilizer too. And just to reiterate what we talked about last time, when you're putting oxygen on these guys, try to put your oxygen line on a mask. It's really going to help to concentrate your oxygen into their upper airway and give them better support than just holding a line to their face. I think that Sam said we've ordered some more masks to have for the ICU and hopefully fit them a little bit better on our oxygen lines. But putting that mask to their face is really going to concentrate that little line of oxygen and help them probably get closer to about 40% FiO2. And just remember not to hold it too close to their face. You want them to be able to at least exhale around the mask so that they're not getting hot and accumulating CO2 and just rebreathing their CO2. So oxygen and fluids are going to be really important for these guys. When we think about fluids, we want to think about some kind of large bore catheter, ideally in a cephalic vein. We talked a little bit last time about the peripheral circulation and where we use catheters and where they're most effective. So cephalic is a little bit closer to the heart, and so it is going to let you deliver volume just a little bit faster than a back leg. Obviously, if you can only get a back leg, then go for it. And sometimes these guys need central lines pretty quickly too, but large bore catheter in a cephalic vein is going to help you deliver volume a little bit more quickly. And then there's a few different kinds of fluids that we talk about. So I'm sure you guys have all seen us using crystalloids. That would really be the most common thing we're going to go for. That's your LRS, your Phyllite or P-Lite, Normar, and saline. And these fluids are isotonic. So that means that they are physiologically similar to the patient and can safely be bolused to the patient. They all have a little bit different sodium concentrations, but all of them are appropriate for fluid resuscitation in a patient with shock and can be reached for as a first line. Does anybody know kind of how we judge how much fluids we give to a patient in shock? This is a good thing, I think, to have like a rough idea of, just so you know if a doctor orders an amount of fluids, if you know, you can feel like, oh yeah, that seems reasonable, or let me make sure I heard them right because I feel like I heard something crazy. Okay, so Brittany said 10-time maintenance, shock dose. Yeah, so usually when I'm thinking about shock resuscitation, I think about body volumes, which I think Emily is suggesting. Maintenance is always a little bit hard for me because maintenance fluids, we're thinking a little bit more about volume that we're giving a patient over 24 hours rather than volume that we're giving them for resuscitation. But a shock dose of fluids, as we call it, is equal to 1 blood volume. And yeah, M has got it on there on the notes. So in a dog, that's about 90 mils per kg. And in a cat, it's about 50 or 60 mils per kg. And so that would be a whole blood volume for one of those patients. So none of us are going to say, let's give a 10 kg dog 900 mils of fluids, right? But what we want to do is we want to split that shock dose into increments. So usually we're going to say, if we have a 10 kg dog, we'll probably say, let's give them maybe 200 mils over 15 to 20 minutes and see how they respond. So usually we talk about either a quarter to a third of a shock dose at a time, and then reassessing the patient. And in kitties, my go-to, if they're like a standard 5 kg kitty, is I'll do 50 mils per cat. Keeping in mind that some cats are a lot smaller, some cats are a lot bigger. So we might change that, but it would be about a 10 mil per kg bolus for a cat, and then reassess. And as you're reassessing, hopefully what you're going to see is that these patients are going to start to stabilize. These abnormal vitals that we're seeing on their triage, the pale mucous membranes, the prolonged CRT, the tachycardia, poor pulses, etc., are all going to start to get better. It's also important to remember that crystalloids are short-lived. So because they're an isotonic fluid, they will redistribute in the body really quickly. And within about half an hour to an hour, only about a quarter of that volume of fluid is going to be left in the circulation. So this would be a great example for using telemetry, like Tommy suggested, where if you can put telemetry on this patient, you're giving them a fluid bolus. Maybe I'm walking around, going to do something else. I can look over and see, oh, good, it looks like their heart rate came down if they were tachycardic. And then if it starts to go back up, that may be a sign that some of that fluid is redistributing and they need another bolus, or we need to come in with something else. So other fluids that we might think about would be a colloid. And this would be something like our vet starch. So these are fluids that are higher in oncotic pressure. They have basically bigger molecules in them that will stay in the circulation longer than a crystalloid. So the nice thing about them is you can give a little bit less. Usually we give about 5 mils per kg as a bolus, and it should last a little bit longer than a crystalloid fluid. We don't always go to them right away because they are associated with both AKI and coagulopathy in some veterinary studies. Coagulopathy. Okay, there we go. The AKI evidence does not seem as strong anymore. And so colloids have been a fluid that have really kind of gone back and forth in popularity because of that. But it is something that we will reach to, especially if patients have low total protein, low albumin, or we're having a hard time getting their blood pressure up. And then I'm just going to briefly mention hypertonic saline. This is one of my favorite fluids because I'm a nerd and I have a favorite fluid. But hypertonic saline is about 8 times as salty, 8 times as concentrated as regular saline. So 0.9% saline is our regular saline. Hypertonic saline is 7.2%. I'm just going to say salty. And so the idea is that you can give a really small volume and get very rapid volume expansion. Does anybody know how that works? It's really cool. It depends on something. So if I get a really salty fluid IV, what is my body going to do? What is the water in my body going to do? So we always say that well, kind of. So Tommy said excrete. So kind of. So the idea is that water will follow salt, right? If you eat a lot of salt, you're going to get really thirsty. Yeah. So Brittany said move from high to low concentration. You guys have the right idea. So the idea here is that we're putting a bunch of salt in the blood vessels, and that salty fluid is going to pull water from the interstitium. So it depends on the hydration of the patient. The patient needs to be adequately hydrated, interstitially hydrated, but it will pull fluid from the interstitium into the blood vessels and rapidly expand the blood vessels. And so hypertonic saline is a really cool fluid to use if you have a really big patient. If you have like a huge Dane that comes in that has a GDV, and you know, a dog like that might need 8 or 9 liters of crystalloids to get stabilized, but you can give a small dose of hypertonic saline and you get about 4 times the volume expansion as what you give. So we usually give a 3 to 4 mil per kg bolus over about 10 minutes. You want to give it over at least 10 minutes because it can sometimes cause some vasoconstriction and some changes in heart rate, and you'll get really rapid volume expansion from that. So this would be something you would reserve for a patient who was previously well hydrated and then maybe had an acute trauma or acutely developed a GDV or something like that. It's also amazing for head trauma because in the same way, it will help to pull fluid out of the brain when there are cases of swelling. So it's good for cerebral edema, and it is just as effective as mannitol. Any questions about those fluids for hypovolemic stabilization? Okay. All right, so we talked a little bit about oxygen. The only other fluid that we really didn't talk about too much is blood products, right? It's not something that we always jump to right away, but it's certainly something that they would jump to right away for us as people in an emergency situation if we had internal bleeding. And, you know, veterinary medicine is interesting in this respect because more and more in human medicine, they're moving towards whole blood transfusion for trauma patients. And maybe we can talk about hemoabdomen or bleeding patients another time, but we have component blood products in our hospital, as we call them. So we have packed red blood cells, we have plasma, we have platelets, all separated, right? Most of the time, unless we're donating a patient that day and using their whole blood. But in people, they'll often use whole blood transfusion. And that's actually what a lot of kind of regular vets out there use because they have a donor that they keep in hospital or their own dog or something like that, that if they need to do a blood transfusion, they will just donate from their dog and then give it to the patient. And this is kind of cool because it provides all of the components of blood. And so if you have a patient who's bleeding, this is actually really helpful because it restores their coagulation factors, it restores their platelets, it restores their red blood cells all at once rather than having to do component therapy like we often do. Component therapy is great, but in some situations, whole blood transfusion can be really helpful. And if we have the products, this is a nice thing to be able to jump to. Obviously, it's physiologic to the patient and it has a lot of kind of additional supportive components compared to a regular crystalloid fluid. So, you know, there are days, obviously, we try to be really stingy with our blood products when we're running low, but when we have them, being able to use them is really great for a lot of these patients. Okay, let's see. What else do I want to say about hypovolemic shock? I think that's about it for those guys. We'll do a couple examples at the end if we have time, but does anybody have any questions about hypovolemic shock? Let's just briefly, just before we go on to the next topic, what are some things that you might see on initial blood work in a patient in shock that we can use for kind of monitoring? We talked about some of these during our triage lecture before. Yeah, lactate. So Emily said lactate. My favorite, right? So by definition, because shock is decreased utilization of oxygen by the tissues or decreased delivery of oxygen to the tissues, your lactate should be elevated. And normal is about less than 2 on our machine. And so anything over 2 would be an indicator of poor tissue perfusion, poor oxygen utilization or delivery to the tissues, and hence anaerobic metabolism. And so this should normalize over time as you resuscitate the patient. And return to normal of lactate is actually a really good indicator in GDV dogs. There's some really nice studies out there that show if you can bring their lactate down as you fluid resuscitate them, it's associated with a better prognosis. Anything else? Yeah, PCV and total solids. Okay, good. So Tracy and Stephanie are both kind of talking about PCV here. So we talked about this a little bit before. You might see anemia, right? If they're bleeding and they've bled enough that you're already going to see a low PCV. You might see a normal PCV, like we talked about before, with a low total solids, because sometimes when these patients bleed really acutely, their solids will drop. And they will have splenic contraction at the same time, especially in dogs. So that PCV will be kind of falsely elevated into the normal range, but their solids will be low. And then also maybe both will be normal when they come in. And as you monitor them, as you fluid resuscitate them, they're becoming more and more anemic. We don't usually shoot for a certain number in terms of where we want their PCV to be, but as a kind of baseline in people, they say they like to maintain patients in shock with a hemoglobin greater than 3. And hemoglobin times 3 is roughly your PCV. So that means about a PCV of 21 for us. And I think I would agree with that, 20 or 21, depending on where a patient starts and how they look, is definitely getting to a point where we're going to start to think about blood products in these guys. Tommy has a question. You want to unmute, Tommy, or you want to type?
I can unmute. I'm sorry, I'm a little sick, but I know that when some patients come in and they're like in shock or some kind of like physiological stress, that sometimes we will like bolus them with LRS. And I understand that we haven't run any blood work yet. Will that like cause an increase in their lactate, or is that not possible really? Or
That is a great question. So if everybody couldn't hear that, so Tommy's question was about using LRS, which is lactated ringers, as a volume expander or as a bolus fluid for patients who have shock, or really patients who have, I think, any medical condition. It's important to realize. So the lactate that is in LRS is not the same as the lactate that we are measuring directly on our blood gases or on the lactate meter. So it's in a slightly different form, and it should not affect their response to treatment for shock or their lactate number on the parameter. So it's a little bit of a different compound than what we're measuring. Make sense?
that makes sense. Thank you so much.
Yeah. The last thing that I wanted to talk about in terms of initial blood work abnormalities is pH. I know this is not necessarily something that we talk about a lot collectively as a group when we're looking at these guys, but running blood gases on these guys is really important, I think, to kind of quantify or objectify their level of shock. But a low pH, which is acidosis, right? Is very classic in shock. You can see what we call a lactic acidosis, where your lactate is high and that acid builds up in the system. And that is not only an indicator of shock, but is also really important to recognize for the tissues, because as the pH drops, you're also going to have more impaired cellular function. So if we're getting less than like 7.2 in terms of pH, we are definitely wanting to intervene with fluids. And if we're getting lower than that, we sometimes will talk about some other measures for treatment, depending on what the underlying problem is. Okay. Let's move on and talk about cardiogenic shock, just so we can focus on this for a little bit. And the tricky thing about cardiogenic shock is that it can look clinically very similar to a patient with hypovolemic shock. So cardiogenic shock basically means that oxygen is not being delivered to the tissues because of some kind of cardiac dysfunction, right? So typically these would be our patients who we think about seeing in heart failure. So poor oxygen delivery to the tissues. And it can be what we call forward or backward heart failure, or right or left-sided failure. Forward failure would be failure of cardiac output, right? There's nothing going forward out into the circulation. Backward failure would be failure of the heart to basically accept and then pump blood. So it could be something like right-sided heart disease, like heartworm disease, or DCM in some cases, and they can develop ascites because they have right-sided failure. Usually in left-sided failure or forward failure, they'll get pulmonary edema. So it kind of depends on where the volume backs up in their system. Why is it important for us to differentiate cardiogenic from hypovolemic shock?
The treatment is different.
Yeah. So the treatment is kind of opposite, right? Like Tracy said, fluid overload. So hypovolemic patients need fluids. Cardiogenic shock patients usually don't need fluids. The only argument I think that you could make would probably be dogs or cats that have pericardial effusion. We kind of lump those patients into different categories sometimes, and this is probably more technical than we need to get, but if you have fluid accumulating in the sac around your heart, we could argue that that's going to push you into right-sided heart failure, right? Because the heart can't fill. And maybe you'll get ascites because of that, but maybe you're also losing volume into that pericardial sac. And so sometimes bolusing those patients some fluids can be helpful for them. But the rest of these patients are not going to get fluids. They're usually going to need diuretics. How might you differentiate a patient in cardiogenic shock from a patient in hypovolemic shock on your triage exam? What might be some clues that would make you say, oh, maybe this patient is not hypovolemic? Good. Yeah. So Kenny's saying tachycardia and rapid breathing. Keep in mind that you can see those both with hypovolemic shock, right? What's rapid breathing called? Tachypnea. Okay. Tracy said murmur and arrhythmia. So good. So auscultation of the heart is really important here, heart and lungs. Okay, good. We have all kinds of things. So weak pulses also might be present in hypovolemic shock. Emily's getting fancy and telling us about pulsus paradoxus. Do you want to tell us what that is? Paradoxus. Hold on. Yeah.
Yeah,
Sure, what that is,
I'd
Em?
love to. It's varying pulse with your respiratory cycle. Is that right? I feel like that's what I recall from a
Yeah,
while
so
ago.
yeah, and when do we see it?
That's a great question. I'm hoping you can tell me.
So what Emily is talking about, this pulsus paradoxus, is you are, let's say you're doing your triage exam and you're palpating a patient's, probably their femoral pulse, and it's probably a dog. And as you're watching them breathe, you're feeling a change in the pulse quality. So the pulse pressure varies with the respiratory cycle. And this is really classic for dogs with pericardial effusion. Because of that fluid that's sitting in the sac around their heart, as the heart refills and the pressure in their chest changes, their pulse quality will change. They will also have something called electrical alternans sometimes, which is not the same thing, but the QRS complex on your telemetry varies in size, basically in tallness. It'll be tall, short, tall, short, tall, short, as the heart swings in the pericardial sac because it's full of fluid. So that's a kind of fun thing. If any of you pick that up on your triage exam and you say to the doctor, I think they have pericardial effusion because their pulses are variable, you get a star for the day. What else do we have? Muddy mucous membranes. Who said muddy mucous membranes? Where are you? I'm going to come back to that in a second. They could have muddy mucous membranes, but what are you thinking about when you say muddy? I think some of us think about some different things when we say muddy mucous membranes. Some people think like brown mucous membranes. Some people think cyanotic mucous membranes, which are kind of bluish, which you definitely might see. Okay, gray, purple. Yep. We'll talk about kind of true muddy again when we talk about distributive shock. Just to come back up here for a second. So auscultation is critical, right? So we want to listen to the heart. Is there a murmur? Is there an arrhythmia? We talked about this a little bit during triage, but putting one hand on their chest to feel their pulse rate, and then putting another hand on their femoral or dorsal pedal pulse to feel their pulse. So you're feeling, heart rate on the chest and then pulse rate. If there's a difference there, that could mean they have an arrhythmia or pulse deficits. So that could be important. What do you want to listen for when you listen to their lungs? what might tip you off that they have, yeah, so Tracy's saying crackles. And that kind of sounds like, I always tell people, I think it sounds like listening to Rice Krispies in your cereal bowl when you pour milk in. It's that, it like truly is this crackly sound when you listen to their breathing. What else might you hear? What if they have fluid in their chest, around their lungs? Will it be easier to hear or harder to hear? Yeah. So we say muffled lung sounds can mean pleural effusion, which we can see sometimes with heart failure, especially in cats, or muffled heart sounds we can see with pericardial effusion in dogs. Wheezing. So wheezing is usually going to be more typical of airway disease, like an asthma kitty. We usually talk about those guys being wheezy, but I think any abnormality in your lung auscultation should prompt you to be a little bit more cautious about your plan for treating their shock and maybe giving them fluids, because sometimes dogs and cats with respiratory disease can also be sensitive to fluids. Anything else? Ooh, yeah. Okay. So Emily said distended jugular veins. So looking at their neck and their jugular veins, if you see distension or you can see pulsing in the jugular vein, that can be an indicator of right-sided heart disease, of poor filling or high pressure on the right side of the heart. So sometimes we'll see that in dogs with pericardial effusion or heartworm disease. And that's a nice little clue too. Great. Thanks, Em. Abdominal distension, if they have ascites, might be a good clue too. Okay, so what's the difference between cardiogenic shock and hypovolemic shock? What's the major treatment here? We said no fluids, right? Usually. What do they need instead? Oxygen. I love it. Yeah, so they definitely need oxygen. Flow by is great. And then diuretics. You got it. So our go-to would be Lasix, which is furosemide. It's a loop diuretic, which means it works in the loop of Henle in the kidneys. The nice thing about Lasix, you guys, is that if you need to give a dose of Lasix to a patient who is in respiratory distress and has heart disease, and you can't get a catheter in, give it IM. I cannot stress this enough, especially if the patient is unstable. Especially if you're having a hard time getting a catheter in, if they're getting stressed, giving it IM is just as effective of giving it IV. It's going to work within 20 to 30 minutes or so. And you can give them an IM dose of Lasix, same dose, and then put them in oxygen or give them some oxygen and give them a little bit of break and come back to them. Usually the dose is 2 mg per kg in a dog and about 1 mg per kg in a cat. Sometimes we go higher in cats depending on how they look, but that would be your standard starting dose for Lasix. There are other diuretics that we use, but Lasix is going to be the general go-to. And sometimes these guys will also need a little bit of sedation to take the edge off. Usually we think about things like butorphanol to start to try to get some x-rays, those kinds of things. And then x-ray is going to be the big thing that's going to give you the most information about whether or not they're in heart failure, right? Okay, questions about cardiogenic shock? I want to keep going because I'm running out of time. Okay, so let's talk about distributive and septic shock. Oh yeah, Dana, do you have something? IM versus sub-Q Lasix. I love it. How well do you think sub-Q Lasix is going to work if you have crap perfusion? Yeah, not well at all. So sub-Q Lasix it's going to take a long time to get absorbed into the system. If the patient is in respiratory distress, give it IM or IV. Long-term for like treatment at home, that kind of thing. If people are doing sub-Q Lasix, which I know we do with some patients, that's fine. But if they're in distress, they need it IM or IV. It's also not going to work very well orally, right? Your perfusion to your gut is going to be impaired because that's one of the first organs that when you have a patient in shock, they don't get good gut perfusion. So don't give it orally, which I think we all know, but just to reiterate. Okay. Let's briefly talk about septic shock. So what does anybody, can anybody give me a definition for septic or distributive shock? This is a tricky one, and I think one that we see, but probably not as commonly. So it's a little bit harder for us to recognize and have a good handle on sometimes. And maybe we should talk about like a few definitions here. So when we think about septic or distributive shock, there's a couple things for us to keep in mind. So bacteremia means that there's bacteria in the bloodstream, right? Bacteremia, bacteria, bloodstream. The next thing that we want to think about is this condition called SIRS, which is the systemic inflammatory response syndrome, which is basically a really fancy term for your body's response to inflammation. And there are 4 key criteria that we use to recognize SIRS, or that a patient has systemic inflammation. And those include heart rate, respiratory rate, temperature, and white blood cell count. There are criteria for both dogs and cats. The most important thing to recognize is, like we talked about before, for heart rate, cats can be low. Dogs are usually high, cats can sometimes be high. Temperature can be high or low. Respiratory rate can be usually high. And white blood cell count can be high or low. And there are kind of specific parameters here, but really we're just talking about abnormalities outside of normal. So a fever or hypothermia, bradycardia or tachycardia, tachypnea, and a high or low white count. And if they have 2 or more of these criteria, they would technically fit the definition of SIRS. And the important thing to recognize here is that this is a really general definition. So it's very, very sensitive, but not very specific. So if I went outside right now and ran around the block and came back, I probably would meet the SIRS criteria, right? My heart rate would be up, my respiratory rate would be up. It's kind of cold out. I don't know what my temperature would be. But it's a screening tool for recognizing patients who may have evidence of inflammation in their body. And then SIRS plus an infection, SIRS plus bacteremia. So your body is showing signs of inflammation and you have bacteria in your bloodstream or an infection somewhere in the body, equals sepsis, right? So it's an infection that is causing inflammation throughout your body and manifesting as clinical signs that are affecting your cardiovascular system. There's a few different kind of categories of sepsis that we think about that I'm going to skip for now, but what do patients with sepsis look like on triage exam? What might be some clues that you might see that would tip you off to say, maybe this patient is actually in septic or distributive shock? Okay, good. Yeah, so Tracy has injected mucous membranes, obtunded or dull, weak, hypotensive, rapid breathing, distended abdomen. Good. So the idea here, yep, febrile, low BG. Yeah, low BG. Okay, I love it. So the idea here with distributive or septic shock is that your volume might be normal, right? You might be normovolemic. You might not be, but you might be normovolemic, but you have this infection that is causing systemic inflammation, and that inflammation is causing poor tissue perfusion or poor oxygen utilization in the body. And what happens here on a cellular level is that because the cells in the body have infection, it affects the vasculature so that the blood vessels can't respond normally. They will be dilated when they should be constricting. And they also can have abnormalities in microperfusion, where there can be swelling at a microcellular level and it impairs the ability of the tissues to use oxygen. There are some really cool little like microcapillary video studies that they do in animals and in people, where you actually can watch each little red cell going through the microcirculation, and you can see it's just like sludging through there. Okay, so what do these patients look like? This is where we'll see kind of two phases of shock, like Brittany mentioned earlier. So you can see early or compensated shock, where they have inflammation within the body that causes usually vasodilation. And their body will try to compensate for that. So they may have injected mucous membranes, like somebody said. If your mucous membranes are injected because you're really vasodilated, what's your CRT going to be like? Fast or slow? Yeah, so it's actually going to be really fast. So if you have this inflammation throughout your body and your blood vessels are all really dilated and red, and they're getting a lot of they have a lot of vasodilation, you're going to have a fast CRT initially. So injected membranes, fast CRT, they're usually going to be tachycardic. They might be tachypnic. Sometimes we'll talk about them having what we call bounding pulses, where because they're so vasodilated peripherally, you can really feel a big pulse difference. They might be hypotensive, but that pulse quality may really vary. They can still have things like dulmentation. What else? They can have arrhythmias. Yep. So all of those things might be similar. And then as time goes on, that body's response to the inflammation kind of runs out, and you can get late or decompensated shock, septic shock. And those patients are the ones who kind of look like they have muddy mucous membranes. Cats will often be bradycardic in this stage. Sometimes dogs too, but usually cats. They'll have poor pulses. They'll be really dull. I feel like those are all of the big things. How do we treat these guys? Do they need fluids? Okay, so Tommy's saying vasopressin. They usually still need some kind of fluids. Yep, I love it. They usually still need oxygen, right? Everybody in shock can have oxygen. Any kind of shock. Good, possible dextrose. Okay, yeah, we kind of brushed over the hypoglycemia, but these patients may be hypoglycemic on your blood work, on your EPOC. That's important to recognize too. Pressors. There's one more thing. Really important. Yeah, antibiotics. I love it. Okay, good. So usually these guys will require some fluids. You know, as we're figuring out what's going on with them, they're going to need a bolus of something. The important thing to keep in mind for patients with septic shock is that they may be less fluid responsive than a patient with hypovolemic shock. So a patient with hypovolemic shock, a hit by car that comes in that has a femoral fracture like Millie, that's tachycardic and hypotensive, you give a fluid bolus to, and usually those patients are going to stabilize fairly readily with a bolus or two. A patient with septic shock, because they sometimes have this inappropriate peripheral vasodilation, they might not be able to respond as readily to your fluid bolus. So you give a fluid bolus and they may have adequate blood volume, but their blood vessels can't constrict back the way they normally should. And so these are situations where we'll give them some fluids. We might try something like a colloid or a hypertonic saline, but we also are going to jump to pressors a little bit more quickly. And that for us will include things like norepinephrine, dopamine, potentially vasopressin. All of these work in a little bit different ways, but they all are going to provide some peripheral vasoconstriction to try to bring up the blood pressure. And ideally, if we're using a pressor, we want a central line, but in many of these cases, we'll start with a peripheral catheter and then move to a jugular catheter, depending on what happens with them. So think about jumping to a pressor a little bit more quickly. Dextrose supplementation is often important if they are hypoglycemic when they come in, but if not, you want to keep a close eye on that. And then antibiotics are absolutely key. So early antibiotic therapy in patients with sepsis has been shown to improve outcomes in people and in animals. Some of the newer studies are not quite as dramatic, but there was a human study when I was a resident that they did that showed that for every 1 hour after a human patient presented to the ER with sepsis, for every 1 hour that they didn't get antibiotics, up to 6 hours, there was a 7% increase in mortality. So getting antibiotics into these guys is key. That's why, when we're seeing these patients in ER and the doctors are really bothering you to start antibiotics, this is why, because we know, think about how far behind we probably are compared to a human patient with sepsis when we realize that as they're coming in, because they're probably sicker at home for longer than people are. So getting antibiotics into them early is really important. And so if you need to put in a second catheter to do that, if you need to give it along with a fluid bolus, those kinds of things, talk to your doctor about a plan for how you're going to do that, because we know that that's really critical. Sepsis is unfortunately associated with poor survival rates in animals, and we can talk about that more in another hour, but usually we're talking about 30 to 40% survival rates, I think, because we recognize it later, because patients are sicker before they come to us. Alexis has a question. You want to unmute, Alexis, or you want to type? While you're doing that, I'm just going to pull up a couple pictures, you guys, and then we can finish up here. I could keep talking for a long time, but I won't. Where'd it go? Let me see if I can unmute you. Hold on. There should be a little microphone at the bottom of your screen. Or you can type it. That's fine. All right, while you're typing, I'm gonna just talk about this briefly. So just to kind of reiterate what shock looks like for many of our patients, this would kind of be a typical patient who we see present with hypovolemic shock, right? Their gums are really pale. We probably can't even get a CRT in this patient. Their pulses are poor. He's probably tachycardic. He looks like he's pretty mentally dull. And patients with hypovolemic shock are going to look exactly like patients with cardiogenic shock in terms of a lot of your physical exam. So this could be a little dog that just got hit by a car that has a hemoabdomen, or it could be a little dog that's in congestive heart failure from mitral valve disease, right? They could look the same when they come in. So doing your auscultation is going to be really important in these guys, like we talked about, in listening to the heart and lungs. Okay, Alexis's question was, if you're unable to get another catheter in, what would you prefer to have running on the patient first, pressors or antibiotics? That's a good question. I think it depends on the patient and how stable or unstable they are. Usually we talk about a systolic pressure of 90 being kind of what we consider a minimum perfusing pressure to make sure that the organs are getting good oxygen delivery. And so depending on what that blood pressure is, your doctor may say, let's start pressors, or they may say, let's give a dose of antibiotics, sometimes a little bit more quickly, and then start the pressor. So always ask them what their preference is. That's a good question, though. And then the last type of shock that we see, this distributive or septic shock, this was a dog that came in with a pyometra, has this kind of classic decompensated picture of shock, where this is kind of what I think of when I think about a muddy mucous membrane, where they just do not have oxygen delivery to the tissues and it's not being utilized appropriately. And there's like a mix of inflammation here as well as poor perfusion. They kind of get this gross muddy color. And this patient may be one that we need to get into surgery as soon as we can get them stabilized. So it's important to recognize the differences in these in terms of what we see when we look at them on triage. The last thing that I wanted to mention is just monitoring these guys for response to therapy. So, we all, I think, get really excited when we see cases of shock, and we really like to treat them and see response to some of those clinical parameters that we're dealing with. But watching for those responses is really important, obviously, to make sure that we're making them better, but also to be able to de-escalate over time. So we don't really have time to talk about this today, but none of these treatments that we're providing are entirely benign. And so it's important to keep in mind that if we're bolusing them fluids, if we have them on a presser, these are things that are going to affect them physiologically. And we do want to be able to take them away as soon as possible, as soon as the patient is stable, because we don't want to get them volume overloaded. We don't want to have their peripheral vasoconstriction be so bad that we're affecting blood delivery to their kidneys, that kind of thing. So monitoring response to time, lactate improvement, normalization of glucose, normalization of pH, blood pressure, all of those things are really important. And obviously you guys are key for as we are providing treatment to these patients. All right, I'm going to stop there because I'm a few minutes over, but does anybody have any questions? Either via
I just have one more question.
Yeah.
Will we get copies of the diagrams that were in the PowerPoint?
Yeah, do you guys want them? I can try, I'll paste it in there and I can send out this little thing I was typing if that's helpful. Okay, I will paste it in there and I can send it out to everybody, or I'll have Jim email it out. Anything else? Any other questions?
Hey, Dr. Beer, I've got a quick question for you.
Yeah.
What are your thoughts on using steroids for shock? And when would you pull for a steroid? I know it's controversial, but personally, what are your thoughts on it?
So, okay, so Emily's question is about using steroids for shock. In general, I think we would all agree that steroids in terms of something like dexamethasone are a no-no in cases of shock. But we do see a condition sometimes where, especially in cases of like a septic or distributive shock, we think that the body runs out of endogenous steroids. So they don't, over time, as they're in that decompensated shock phase, they kind of lose the ability of their body to produce cortisol, or they're not making enough cortisol. And in some situations like that, you guys have probably seen us do either intermittent hydrocortisone at very low doses or hydrocortisone CRI. The idea being that hydrocortisone is a little bit more physiologic and provides that endogenous cortisol-like substance that the body needs. So it's definitely not something that I jump to, but we do use it in those rare cases or in patients we see where they're really not responding to anything else. And doing a baseline cortisol would be helpful too, just to kind of document that it is low. Or they talk about delta cortisol in people where they actually do a stim and make sure that they don't stim appropriately. And that's a little bit more evidence to say, yeah, they do need a little bit of steroid.
Perfect. Thank you.
Yeah. You guys too, if you want to let me know over text or over email or in person next week when I'm in, if you like this format, please just give me some feedback. I kind of like to be able to talk and have more of a discussion, and I'm sorry we don't have room to do it in person, but it's more fun for me. So if you guys don't mind it, I would love to know that. Or if you prefer PowerPoint, I would love to know that too. And I'll turn off the recording and we can get out of here.